Good day. We are busy, still busy with the Mother Baby Friendly Initiative. And this is session 5. It's the last session of all the series. And I am still Anna Nolte. And today we're going to talk about the possible problems from the mother's side. The previous session, we've talked about the possible problems from the newborn side. Now we're going to talk about it from the mother's side, and we're also going to talk about support after discharge. So in lesson 1, we're going to talk about the big problem, not enough milk, and then nipple conditions, engorged breasts. Then I'm briefly going to just talk about the breastfeeding and the HIV mother, and then the other 10 steps that we haven't done yet, and specifically we're going to talk about support after discharge from the mother from hospital. Okay, so in this lesson we're going to talk about the big problem, not enough milk. Not enough milk is a major worry during the first few weeks postpartum, and it's one of the most common reasons given by mothers for early weaning and for supplementation. And I think it's one of the complaints, questions that you hear the most, even still when the mother is in hospital, but also so much more when she's going home and the first week, 2 weeks after discharge from the hospital. This is one of the biggest problems, and as we've said, the most common reason why mothers give up breastfeeding. What I'm saying here under the NB is so important. It's actually milk production insufficiency is quite rare. There are very few mothers, and in very few cases, where there's really insufficient milk production. Now, this problem or this complaint about too little milk has many possible reasons. Now, the first one of all is unrealistic expectations of infant behavior. Now, the reality is very important that baby needs frequent feeds because their stomach's capacity is very small, and their stomach capacity parallels the lactation secretion patterns. We have said that so many times before, that the breast secretes and forms as much milk as being demanded from the baby, and because he demands small amounts at the time, he needs to be fed more frequently. Now, the unrealistic expectation is that the mothers expect breasts or babies to sleep or to go for long stretches between the large meals. And this is very unrealistic. It's physiologically unrealistic, it's inappropriate, and it's counterproductive. Counterproductive in the sense that, as we've said, the baby needs smaller, frequent feeds instead of big feeds, large feeds with long stretches in between. Now, any event, and we have said that so many times, and you will hear it quite a few times in this lesson as well, any event, behavior, custom, or practice that keeps the baby away from the breast or causes milk to remain in the breast, in other words, the baby is not emptying the breasts for longer than 4 to 6 hours apart, has the potential to inhibit milk production. And we have talked so many times about this before. And these factors include then scheduled feedings, especially during the first few weeks, first 1 to 2 or 3 weeks, if feedings are not being given frequently. Scheduled feedings that's 4 hours apart is one of the big reasons for this, the fact that the breasts are not being stimulated enough, or the use of bottles without corresponding expression of milk. So the baby is being given supplementary foods of formula foods, and that makes that the baby obviously don't need more food, and doesn't often enough empty the breast. Or the use of pacifiers so that the sucking time of the breast markedly decreased. And we have in the previous session, we have said that evidence has shown that babies who are using pacifiers has at least one breastfeeding per day less than babies who are not using all pacifiers. And then obviously also in the case of some maternal and infant illnesses, there might be reasons why the baby is not drinking often enough. Now, very important is, as we've said, there's very few mothers who do not have enough milk. I'm saying here, most mothers have sufficient lactation capacity to synthesize at least 1/3 more milk than what their baby typically takes. So the mother has the capacity to produce enough milk for the baby. But as we have said now many times before, and many times even before in this lesson, that if the breasts are not drained properly, if the breasts are not drained of about 2/3 of the milk, most of the time by the baby suckling or by expressing, the rate of milk synthesis slows down to match the lower demand. That's what we kept on saying, that the breasts are producing as much milk as is being demanded from by the baby. And then what's very important also is that breast storage capacity also matters. Mothers have different uh, milk storage capacity. Some mothers have smaller milk storage capacity than other mothers, and they need to feed their babies more frequently. The breast can store so much milk, and because of that, the baby needs to be fed more frequently. Other mothers have larger storage capacity, and obviously their babies might drink more at one drinking session, if I can call it like that, and they can feed at longer intervals. That also depends on if the baby is willing. Some babies can drink more, some babies drink less, so this all depends on, again, individual differences in the mother and individual differences in the baby. Now, if a baby for some reason cannot remove sufficient milk from the breast, as we've said now, the milk synthesis will be quickly diminished unless the mother begins to pump or express breast milk. And we have said that many times. When the baby is sick or when the baby is refusing the breast, the mother needs to keep the breast to produce milk by pumping or expressing the milk. Regular removal will maintain the mother's milk supply and will cause until the cause of her baby's poor suck are being investigated or being improved. Delayed, we're still busy with the reasons for, or possible reasons for, insufficient milk supply. Delayed onset of lactogenesis 2 is associated with a less milk supply, and it's also associated with several factors. Remember, lactogenesis 1 is the production and the preparation of the breasts for production of milk during pregnancy. Lactogenesis 2 is the start of the production of milk immediately after the birth of the baby. And it might be a delayed onset of this lactogenesis because of cesarean births, and specifically in the case of general anesthesia, high levels of stress to the mother and the fetus during birth, and specifically with prolonged or very stressful births. Premature delivery, we have said that in premature delivery, very often the breasts, depending on at what gestational age the mother gives birth, the breasts are not totally, I almost want to say, ready and developed for breastfeeding, and that might be a reason why the lactogenesis 2 is being delayed. Insulin-dependent diabetes mellitus might be a reason. Obesity and endocrine disturbances might be another reason. And then if frequent and effective breastfeeding appears to be the most important factor in establishing normal lactation. So in the cases where there was not early, like in the first hour after birth, frequent on demand, and effective breastfeeding with good latching where the baby is emptying the breast. These are the possible reasons for a delayed or insufficient milk production. Prolactin bursts, we have said, are associated with the infant suckling or the breast pumping. And if this doesn't happen, obviously there's not enough prolactin that's been secreted and not enough milk being formed. Very few women are physically unable, as we've said before, to make sufficient milk for one baby. Now, there are signs, reliable signs that the baby is not getting enough milk, and then there are some other possible signs that's not always so objective. That also might be a indication that the baby is not getting enough. The most reliable signs are the fact that the baby is not gaining enough weight, and we can see that on the growth chart of the baby, that the baby is not gaining weight according to his or her percentiles, or after, we remember the baby is usually losing weight the first few days after birth, and then start gaining weight. And then from the second week onwards, the baby is supposed to gain more or less 500 grams per month. And if it doesn't gain that amount of weight, that might be an indication that the baby is not getting enough milk. And then the number of times that the baby passes urine per day should at least be 6 times per day. Small amounts of concentrated urine passed less than 6 times a day might also be an indication that the baby is not getting enough milk. Other possible signs that the baby is not getting milk, the reason why these are not so reliable is, and I will talk about that, is that there are also possible other reasons for this. Like, for example, the baby is not satisfied after breastfeedings. There might be other reasons why the baby is not satisfied after breastfeeds. He might be uncomfortable because he drank too much, or he might be uncomfortable because of a wind, or he might be uncomfortable because of reflux, etc., which we will come to just later on. The baby cries often. There are many other reasons or possible reasons why the baby can also cry except for being hungry, and we will come to that just now as well. Very frequent breastfeeds, the baby asks for breastfeeding often. Now, there might also be some other reasons why the baby is asking more often than just because he's hungry. And the same with very long breastfeeds, that the baby stays on the breast for longer periods in an effort to get as much as possible milk. The baby refuses to breastfeed. We have talked about that also in the previous session, and there are many other possible reasons why the baby refuses to breastfeed. The baby has hard, dry, or green stools, or infrequent small stools. No milk comes out when the mother tries to express. Now, this might also be very much related to a delayed or a not good enough lay-down reflex, because remember, this whole issue about the mother not having enough milk is very stressful to the mother. And we have said, and she has a lack of confidence. And those are the things that we have said are very important for the lay down reflex. A good experience encourages the lay down reflex. So the fact that there is no milk that comes out when the mother tries to express might be because she's too stressed about this whole issue of not enough milk. The breasts did not enlarge during pregnancy. This is actually might be a more reliable sign, because often the breasts might not enlarge because the breast tissue has not been formed during pregnancy. And then milk did not come in after delivery. We have said previously that some mothers can clearly experience when the milk comes in, and other mothers are not so, can't really put the finger on exactly when the milk came in. So this is also a subjective experience. Some other breastfeeding factors that play a role in this not enough milk situation is a delayed start of breastfeeding. We have talked about that also many times. If a baby does not start with the breastfeeding on the first day, specifically immediately after birth, and then within the 21st 24 hours, the mother's milk might also take longer to come in, because this whole hormonal prolactin stimulus is then, I almost want to say, delayed. Infrequent feeds we have talked about many times now already, and specifically when these feedings are far away, far apart from each other. When a baby, for example, gets less than 8 breastfeedings per day during the first 4 weeks, or fewer than 5 to 6 times a day when the baby is older, because remember, the breast needs to be stimulated to form milk. Some babies are content Like we've talked so many times about personal individual differences, some babies seem to be content and happy, but they do not show that they are hungry often enough. So it's difficult to feed these babies on demand because they literally don't demand feeding. And it's like similar with us adults. Some people go long periods without food, and other people like me have to eat more frequently. So it's the same. Some babies are on content and they don't ask, but then when one look at the weight gain, we will see that they don't really gain enough weight, because and they don't get the breasts are not also producing enough milk for them, because as we've said, the breast needs to be stimulated frequently. Also, that's the same babies that might not ask for night feeds. And remember, we've said initially night feedings are very important because that's when most of the prolactin are being stimulated, or the production of the biggest production of prolactin being stimulated. Also, very short feeds. The mother might take the baby off when the baby pauses. Remember, we've said that babies have drink periods and pause periods, and specifically when the mother is in a hurry, she might take the baby off too quickly. As soon as the baby pauses, she might interpret that as that the baby had enough food, and she takes the baby off the breast before he really has eaten enough. Now, some aspects around the mother's physical condition might also contribute to this problem of not enough milk. For example, the contraceptive pill, which contains estrogens. Remember, estrogen and progesterone suppresses the formation or the excretion of oxytocin and prolactin. So if the mother drinks this in an artificial way, specifically estrogen, it definitely reduces the secretion of the breast milk. Now, progestogen is a form of progesterone that does not have that serious effect on breastfeeding. It does not reduce the secretion of the hormones and the secretion of milk. But it's also advisable that mothers should not start with them before the baby is at least 4 weeks old. So mothers should have education on this aspect. It's progestogen pills and Depo-Provera that we're talking about. Diuretics might reduce the supply of breast milk. Now, we have said that during pregnancy, the mother has the blood volume increases, and then during the postpartum period, the body needs to get rid of all those excessive blood volume, and that causes that the body's fluid balance is a little bit dermakar, if I can call it like that, and the mother suffers from a lot of edema, especially in her legs and her feet. And if diuretics are being given for that, that might also be the reason for a reduction in the breast milk supply. If the mother becomes pregnant again, because remember there's a placenta with progesterone and estrogen, which suppresses the formation of breast milk, so there will be definitely a reduction in a supply of breast milk. Severe malnutrition, and it's only in the case of severe malnutrition that it might have an effect on the milk production, because I almost want to say the breast milk, or the formation of breast milk, is almost a parasite in the body of the mother, because even if the mother is mildly or moderately undernourished, the body will still use as much as possible of the mother's nutrients to produce milk at the expense of the mother's own tissues, so that the baby eventually gets enough milk when if he suckles enough. Alcohol and smoking might be a reason for less milk production. Retained pieces of the placenta is a rare possibility, but if some pieces of the placenta stay behind in the uterus, it also causes still the production of estrogen and progesterone, And it's only when this becomes septic or when the mother starts bleeding and it's been removed from the uterus that the mother will start producing enough milk. Poor breast development, that there's in very few cases of mothers, there is a problem where the breast's not been developed sufficiently, an increase in size during pregnancy, and she does not produce much milk. But as I'm saying, that is a very rare occasion, and mostly mothers produce enough milk. Conditions of the baby that might help contribute to not enough milk. Illnesses, when the baby is ill and can't feed, but we have said that in those cases the mother should express her breasts to still stimulate the breasts to produce milk. Babies who have a congenital problem such as a heart abnormality and the baby gets tired very quickly and the baby might fail to gain weight. These are reasons, because then obviously if the baby gets too tired too quickly, the baby's not stimulating the breasts enough to produce milk. But this is also then an indication where the mother should express milk. We have talked about the cleft palate in the previous session, and all the other babies with neurological and congenital problems, like, for example, mental disabilities, where they don't have all the suckling reflexes being sufficiently developed, for example, the sucking reflex and the gag reflex, etc., and they can't sucking efficiently for the breasts to produce milk. Now, this is just a summary of all the reasons, possible reasons why a baby might not get enough milk, and it's been divided in common conditions or common reasons and not so common reasons. And here you can see all the breastfeeding factors that we have talked about are common factors, as well as the maternal psychological factors. And we have talked about the maternal psychological factors many times as well. The maternal physical and the baby's condition are not the less common reasons why a baby is not getting enough breast milk. Now, how do we manage this problem? Now, first of all, the very, very most important thing is to do a proper assessment. I think that is logical, that we can't, in any case, with any problem that we are dealing with, we need to do a proper assessment in order to determine what's the real problem. Now, in breastfeeding, exactly the same story. We have talked about in the very first session about all the counseling skills that's necessary to take a good feeding history. And we have talked about the fact that by using some good counseling skills, we get much more information from the mother than by using bad counseling skills. Now, I will attach at the end of the slide I will attach an instrument that you can see. In fact, it's basically the next slide. You can see an instrument that can be used to do a good feeding history. And after we've got a good feeding history from the mother, and we have assessed a breastfeeding session to check whether the mother and the fetus, the baby, are in the correct positions, and whether the latching and the attachment is correct, and to look also for signs of bonding and rejection, which we've said play a huge role in the let down reflex in the oxytocin production. We have, and I've shown you a previous instrument that you can use for this. So a combination of these two instruments should help you to do a proper assessment of the breastfeeding, the history in total, and specifically the breastfeeding as such, to see what are the possible problems. You can also should use your observation skills to look for illnesses or physical abnormalities in the mother and or the baby. And then whatever you suggest to the mother, or what you educate the mother, or what advice you give to the mother will obviously depend on the cause of the insufficient milk. Now here you can see the instrument, the feeding history up to 6 months. And the aspects that's been tested are all these facts: the feeding itself, the health of the mother and the baby, pregnancy and labor related aspects, the mother's condition and family planning, is she on contraceptives or not, previous infant feeding experience, because that might have play a big role, and then also factors, family and social situation factors, where the family might place some pressure on the mother, etc. Now we will also attach this instrument in a PDF form for you so that you can print it out and can see it more clearly. Now, as I've said previously, this might also be a very subjective topic about whether the baby is getting enough milk. There are babies who are really not getting enough milk, but then there are also babies who are getting enough milk, but their mothers think that they are not getting enough milk. And what should we do? How should we manage this? Again, we should use our counseling skills to take a good feeding history and find out why exactly does the mother think that the baby is not getting some sufficient milk, and to learn to understand what caused the mother to doubt her own milk supply. We should explore the mother's own ideas and feelings about the milk and the pressures that she might experience from other people regarding breastfeeding. And specifically, family members and close family members often play a big role. We have said that we should assess the breastfeeding, and here again one should assess the breastfeeding to check the positioning and the latching, etc. And like we have said when we have talked about the counseling skills, very important to praise the mother about the good points about her breastfeeding, the technique and the things that she's doing correct, and then to correct the mistaken ideas without sounding critical, and again using our counseling skills to help her right when she is wrong. And then very important, these mothers are at risk of introducing other foods and fluids and needs a lot of support until their confidence is built up again. Because they think that they're not having enough milk, they're very quick to give the baby supplementary foods, or put the baby on solid foods very early so that he can have enough in additional foods, because they keep on thinking that the baby is not getting enough milk, and therefore they very quickly stop. Just a few words on crying babies, because this often plays a big role on mothers' perception that the baby is not getting enough milk. A baby who is crying too much, in inverted commas, might really be crying more than other babies, or their families might just be less tolerant of the crying, or they don't have the skills of comforting the baby. So all this makes that that they experience the baby is crying too much or much more than normal babies, etc. And it's also very important to note, and I think we all know it, that families' responses to crying is different in different societies and in different cultures as well. Now, there are definite reasons for a baby who's crying much more, amongst which, for example, are allergies. The babies can become allergic to the protein in some foods of their mother's diet. For example, cow's milk, soya, eggs, peanuts, etc. Now, this is a problem that's not easy to detect and to find out. This is causing a lot of trial and error and in examinations, etc. So this comes over a period of time. It's not going to be a solution for this over one day. Other possible reasons for babies crying too much might be that the mother is taking in a lot of caffeine in coffee or tea or colas, and that's been passed into the breast milk and upsets the baby. And again, here all these things, the individual differences play a big role. Some babies might be affected by caffeine, and some babies might not be affected by caffeine, like some of us are being affected by caffeine and some of us are not. If mothers smoke cigarettes or take other drugs or take alcohol, especially alcohol and drugs have different effects on different babies. Alcohol, for example, might make a baby more active, or it might make a baby more drowsy. So it's again, to a large extent, a trial and error effect. Baby's breast refusal, we have talked about the previous session, where the baby was always drinking well on the breast and now suddenly refuses breastfeeding. Then reflux might play a big role in many times, that when babies are crying, and specifically crying a lot immediately after birth. And this is because of a gastroesophageal reflux. And this is almost having the exact effect of heartburn that heartburn has on us, because it's when the milk and the acid from the stomach passes back into the esophagus, and that makes it sore because of this burning effect on the acid on the esophagus, and that makes the baby to cry. These babies might also regurgitate small amounts of milk after their feeds. Now, this is a very common as a common defect, if I can call it like that, in babies who had been tube fed, specifically babies, preterm babies who had been tube fed for a long time. And these babies are uncomfortable, and they cry a lot, particularly when they are being lied down, because that's when we get this reflux, more reflux than otherwise. And the babies cry less when they are held in an upright position, and specifically being put in an upright position after their feeds. If they've been put in a baby chair or some other chair, that they can sit into a more upright position, so that the milk does not pass back so easily. We have talked about colic last time when we talked about the fact that mother breastfeeding babies can also develop colic. And then also there are high needs babies who are just crying more than other babies, and they just need to be held and carried more and been given a lot more love than other babies. Another reason for babies crying is hunger due to a growth spurt. We have talked about that also when we did the physiological changes of breastfeeding. The baby is now growing much more, so the baby needs more milk, and then he seems to be very hungry for a few days. And then as soon as the breast starts producing enough milk for this baby, then the baby gets satisfied again. After that. So the baby's demands to be fed more often, and the most common ages for these growth spurs are around 2 weeks, 6 weeks, and 3 months, but there's also a lot of individual differences. And we have said that if the baby is having a growth spurt early, around 2 weeks, the mother can put the baby, we talked about the breastfeeding holiday, if you remember that correctly, the mother and the baby get into bed and feed as often as possible till the baby is being satisfied. And here at 6 weeks and the 3 months, the mother just needs to feed the baby more often till the breasts are producing more milk, and then the baby usually stabilize, the whole process usually stabilize. And if the baby, as we say, suckles more for a few days, the supply increases and the baby gets happier and satisfied again. Mother's food might play a role. Now here is also, we've said some babies can get allergic to some of the mother's food, but some, like in us, some people are just more sensitive to some foods than other people, and the same with babies. The mother sometimes just notices that the baby is upset when she eats particular food, and this is very difficult because it can happen with any food. So as I'm saying, some people are more sensitive to some certain types of food, more spicy food, less spicy food, etc. So this all depends. So it's very difficult to advise the mother on what foods she should avoid. This is really a kind of a trial and error type of effect that the mother till the mother learns what affects the baby or not. Now, this is also an instrument that one can use to help a family with a baby who cries a lot, to first of all look for the cause of the crying, and then also to build confidence and give support. Now, this instrument I will also give to add to you in a PDF format so that you can print it out and see it clearly. But first of all, obviously, a good assessment and a good history should be taken, and then all the ways in which this mother can be supported. Then just lastly, And we have talked about this also in the previous session, is about too much milk. The mother that's having an oversupply and an overproduction of milk, because in this case, the baby also uh, uh, almost kind of looks like he's uncomfortable, he's not happy after a food, after a feed, and then it's not because of too little milk, but it's rather because of too much milk. And in this case, usually when when the lay down reflex happens, this baby starts choking, twisting, and pulling back to escape this sudden flow of milk upon the lay down reflex. And then also, the other sign of too much milk is that the mother's breast might leak to a point of interfering with daily activities, and she often complains about wet clothes and embarrassment in public areas when suddenly she becomes uh, wet, the breast milk. When she thinks of the baby, etc., and the lay down reflex happens, then she might leak, and it might be a embarrassment for her. Now, the one huge positive thing about this is also that, as we've said many times, the breast starts to stabilize, to regulate itself, to produce what the baby asks from, and this usually happens within the 6 to 8 weeks postpartum. So again, we need to educate the mother on how to deal with it up to the 6 to 8 weeks after it starts stabilizing. But one should also be very careful not to, if the baby, for example, consistently chokes when the mother's milk lay down comes in, this is not necessarily because of oversupply of milk. We should very carefully evaluate and assess the baby as well, because this can often be because of a lack of his gag reflex, the suction reflex is not good, etc. So there might be problems around the baby and his suckling instead of just too much milk. So before we just decide that the problem is oversupply of milk, we must carefully evaluate the situation, like in all cases, in all situations. And then how to manage this situation is to use only one breast at the feeding and really empty that breast for the baby, to help the baby to empty that breast instead of switching from one breast to the other. Because if the baby gets a lot of milk from the one breast in 5 minutes and been switched to the next breast and also get a lot of milk in 5 minutes, the baby gets a lot of milk, but all of that is fore milk, not hind milk. So it helps to, if the baby finishes one breast, so that he also can get the hind milk. And then to pump or express, which one should be very careful, because remember the breasts produces as much milk as is been taken from the breast. So if the baby drinks a lot and we pump and express milk as well, the breasts are just going to produce more milk. So the only way, or the only reason why one should pump or express milk here is just to relieve this tension. If there is this tension, and we will come to that again when we talk about milk stasis and engorged milk, to just relieve the distension and the discomfort, and not to empty the breast, as we say, that will just cause more production of more milk. And then different positions the mother can, we can educate the mother to experiment with different positions, also to slow kind of the flow of the milk, especially when the baby is so-called higher than the breast. The mother's lying in a reclining position and the baby facing downwards. We have talked about the baby being on the mother's abdomen and the baby facing downwards, and to a certain extent gravity helps that the milk is not flowing too fast. But if this is going on for a long period, and as we've said, the breast should stabilize, and if it doesn't happen that the breasts are stabilizing, then a full assessment should be done of the breast, with the breast history, feeding history, etc., like we've said before, to really determine what the problem is. And that brings us to the end of this lesson, this enormous problem. And please complete your quiz before you can continue to the next lesson.